Hi everyone, thank you for joining us today. You have tuned into the Equal Hope segment on CAN TV. We have a segment from 5 to 5:30 every fourth Tuesday of the month. My name is Leilani Lacson, and I am the data coordinator at Equal Hope. For those of you who are unfamiliar with Equal Hope, we are a nonprofit organization in Chicago whose mission is to eliminate health disparities in Illinois. And we do this by offering free mammograms, free cervical cancer screenings, and follow-up. We provide assistance with scheduling vaccine appointments such as the HPV vaccine, flu vaccine, and COVID-19 vaccine. Visit us at Equal Hope today to learn more about us, or you can give us a call at 312-942-3368. You can also find us on social media. So let me introduce this month's guest. It's Dr. Claudia Perez. She's a breast surgery oncologist at Rush University Medical Center. Dr. Perez, thank you for joining us this month.
Thank you for having me.
This month is National Cancer Control Month, and we will be discussing breast cancer and the Latinx community. Breast cancer is the most common cancer diagnosed among women, as well as the leading cause of cancer death among women worldwide. Although the number of deaths have decreased nationwide, there are existing breast cancer mortality disparities among the Latinx community. In the U.S., the rate of breast cancer in the Latinx community is lower than non-Hispanic white women. However, the Latinx community is more likely to be diagnosed at a younger age and with more aggressive disease, such as triple-negative cancer, which has fewer targeted treatments. They are also about 30% more likely to die from their breast cancer than white women. In addition, the ongoing COVID-19 pandemic may worsen these health disparities. So Dr. Perez, tell us a little bit more about yourself and how you got into the medical field.
Sure. So again, my name is Dr. Claudia Perez. I'm a breast surgical oncologist, which means that I take care of a lot of patients with breast problems, whether that's benign disease or and especially cancers. I did my training in general surgery, which I am board certified in, and then I did my fellowship in breast surgery, which is a year of training at Northwestern University, which brought me to Chicago. I've since worked at Loyola University and Mercy Hospital, and now I'm currently at Rush University, where I again do primarily breast cancer surgery.
Okay, great. So tell us what the current breast cancer screening guidelines are for women.
Sure. So let's start with women of average risk. What we recommend is a screening mammogram at age 40 and annually thereafter. So that's a mammogram once a year. If you are at higher risk, then we would recommend mammograms 10 years prior to the age of diagnosis of the primary first-degree relative's age. Mm-hmm. For example, if someone's age of diagnosis was 35 in your family, mm-hmm. then we recommend imaging 10 years prior. Now, it's not always a mammogram in young women. We use ultrasound in younger women because it is more diagnostic for them. Mm-hmm. But in summary, we really want women to get a mammogram at age 40 and annually thereafter.
Okay. So there are two different types of mammograms. Is that correct? The screening and diagnostic mammogram?
Yes, you are correct. A screening mammogram is the type of mammogram we get for patients who don't have any concerns. Mm-hmm. So you don't have a palpable mass or mm-hmm. lump. You don't have any complaints like pain or changes in the skin. Mm-hmm. The screening mammogram is a two-view image of the breasts mm-hmm. on the right side and on the left side. Mm-hmm. That's different than a diagnostic mm-hmm. mammogram, which is done in women who do have a complaint or some sort of breast concern, whether that's a lump or some other concern in the breast like pain or, again, skin changes, nipple concerns, nipple discharge. Then we do a diagnostic mammogram, which allows us to do multiple images of the breast using mammogram technology mm-hmm. to really qualify the concern.
Okay. So you talked about some symptoms of breast cancer. What are some other symptoms besides nipple discharge and pain?
Well, most concerning is if you feel a lump. Mm-hmm. Now, sometimes that's hard for people to decipher because breast exams and the self breast exam can sometimes be tricky and confusing to many people.
Mm-hmm.
It's hard to know what's normal and what's not normal.
Mm-hmm.
So really, we advocate any change in what your breast normal is. Really bring that to your doctor's attention. So whether that's a lump, something that feels different, something that looks different with the skin, with the shape, with the size, if that's changed, and then anything concerning in the nipple areolar complex, whether that's physical changes or nipple discharge, or anything you feel underneath your armpit in that axillary lymph node region. Those are all some of the main concerns. So really, if you have any new changes in your breast, you should really bring it to your doctor's attention for an exam.
Okay. And are you an advocate for self-exams?
Well, the guidelines kind of have been leaning against self-breast examinations. We don't really push for them the way we used to, where you had to do it every month, the same time every month, in the same way. Again, it's that concept or philosophy of being more self-aware, understanding breast changes on the day-to-day without feeling the anxiety of that monthly self-breast exam, which can be confusing and almost anxiety-provoking.
Okay. So I've heard of the term dense breast tissue, and there are women out there who have dense breast tissue. What exactly is dense breast tissue?
Sure. The breast tissue is made up of a combination of fatty tissue and fibrous tissue. If the fatty tissue is the most predominant part of the breast, that's a fatty breast. If the fibrous component is the more predominant look of the breast, then that's dense breast tissue. It's not something you really necessarily feel. It's something that's seen on mammograms. And so one of the newer pieces of information that we provide on mammograms is a comment about breast density, because that's very important in terms of understanding how you can be properly screened.
Okay. So fatty tissue and dense breast tissue are different things then?
They are. There's 4 categories of breast density. Fatty is category A. Extremely dense is category D. So A, B, C, and D. C being heterogeneously dense, and B being fibroglandular. So women who are in categories C and D really qualify for additional supplemental imaging because of breast density. Find that we need more than just the mammogram to really get a good look at the breast tissue if you are category C or D density.
Okay. How common is dense breast tissue in women, and who's most affected by it, do you think?
Well, the distribution is 10% of women have category A, almost completely fatty, and 10% have category D, extremely dense, with 40 and 40% in categories B and D. So it's really not a specific type of woman. It's really the way you're built and your anatomy, and we learn about your density when we do a mammogram.
Okay. So you talked about a screening mammogram and diagnostic mammogram, and there are some other tests that women can have for their breasts and to see if they have breast cancer. So one of them is an MRI. What is an MRI?
So an MRI stands for magnetic resonance imaging. It's another way that we can look at the breast tissue. It's really indicated in women who are at high risk. And we also use MRI quite a bit in women who are newly diagnosed with breast cancer. Again, if you have dense breast tissue, MRI is a nice tool to look at the breast tissue supplemental to the mammogram. MRI is very sensitive, not always specific, but we like to use MRI in the right patient population when we're trying to screen them appropriately.
Okay. And does an MRI involve the dye, or is that something else?
There is a dye injection called gadolinium that you get during an MRI.
Okay. And then there's an ultrasound. That's another diagnostic tool.
Yes, ultrasound is almost an extension of our physical exam and our mammogram. Ultrasound is used as a supplemental tool with diagnostic imaging. Like a diagnostic mammogram may require a diagnostic ultrasound to do focused imaging on a certain area of concern. We also use screening ultrasound in the women who have dense breast tissue. So it's an important tool that can distinguish sometimes between solid masses and fluid-filled masses, and also helps us better qualify someone's mass or cancer.
Okay. And then when would someone have a biopsy?
So anytime we have an indeterminate finding, something that does not look benign on imaging, we would recommend a biopsy. And there's several types of biopsies that we can do. But essentially, a biopsy is taking a sampling of the tissue, a core sample of it, so we can analyze it under the microscope and understand exactly what the diagnosis is.
Okay. So for someone who hasn't had a mammogram yet, I'm actually like a few years away from it, what can I expect when I go in for my first mammogram?
Yes, many women feel nervous or anxiety about the mammogram. We have very skilled and trained technicians and breast radiologists and radiologists who do the mammographic imaging. You can expect that for a screening mammogram, they're going to take 2 views of each breast. The breast will be placed and compressed in the machine, which is essentially paddles, so that we can really compress the tissue and see anything that's within the breast tissue. It takes less than 30 minutes for a mammogram and usually very well tolerated. Although some people feel pressure and some discomfort, it's usually not very long lasting.
Okay. So what are some of the things that patients have told you, of what you've heard from your colleagues about why men or women decide not to get a mammogram?
Well, usually it can be fear. Women are afraid, or men may be afraid of what they're going to find or concerned about what that's going to mean. Some women don't have access, and that's why mammograms can often be delayed. A lot of times it's because of stories they've heard from other women about the experience. And I'm here to say that the majority of women do just fine with a mammogram. So it's really important to do that once a year as your screening tool, because we have such great screening for breast cancer. And it's such a shame when we don't use that to help us diagnose breast cancers early.
So I mentioned that men can come in to get a mammogram. Are the screening guidelines the same as for women?
No, because breast cancer in men is much more rare, there are no mammographic screening guidelines for men. So men typically come in when they feel something, like a lump, usually around the nipple areolar complex, or changes in the nipple, whether that's nipple retraction or dimpling, or physical skin changes in the nipple. So once that's detected, it's very important to tell your doctor, so then we can further do the workup to diagnose the problem.
And it's rare in men?
It's more rare and much more rare in men, correct.
Okay. So how can men or women get a breast cancer exam? How do they go about getting a referral and scheduling and all that, the whole process?
Sure. So for an exam, you can go either to your primary care physician, which doesn't require a referral, or your gynecologist, or you can see a breast specialist like myself in a breast clinic. At Rush, we have our own dedicated breast cancer clinic where any one of the many doctors can see you for a good breast exam.
Great. So how can men or women, when will men or women obtain the results after having a screening done? How long does that take?
Sure. For a screening mammogram, the turnaround time is usually about 24 hours.
Oh, wow.
24 hours, you'll know the result. For diagnostic mammograms, the results are on the spot right away.
Wow. I didn't know it was that fast.
Yes. I mean, it can vary from institution to institution, but we really make it a priority to get women their results quickly. Usually the report will go out, and if you have access to MyChart or the electronic records, usually it's available to a patient within 24 hours.
Okay. So what does it mean when someone's result comes back as abnormal?
Right. So abnormal doesn't necessarily mean cancer. Often women get called back after screening mammograms because of subtle findings that aren't clear on the screening mammogram. So they're often called back for additional imaging, which is called a diagnostic imaging, whether that's a mammogram or ultrasound. With the additional imaging, we can further qualify whether or not this is something that is normal, benign, or is it something that is indeterminate, which then would lead to a biopsy. Should
women or men be afraid if they get a call saying that the results are abnormal?
You really shouldn't. It's very common, especially with the first screening mammogram, that there are subtleties that are seen that we need to do additional imaging for. It shouldn't be scary because it's common, but I understand that women get nervous about it. I really am here to say that most of the time we clear it with the additional imaging and everything is just fine, or we need to follow it up in 6 months with short-term follow-up imaging. That being said, we do find other abnormalities and even cancers when we call women back, but that's not the most common scenario.
That's good to hear. That's very encouraging to know.
Yeah.
So let's talk about the Latinx community. What are some of the factors that put women at higher risk for breast cancer?
Well, there are some modifiable risks, and then there are some non-modifiable risks. Number one, let's start with the modifiable risks. Lifestyle factors such as smoking can increase your risk for breast cancer. Other things like hormonal influences, taking exogenous estrogen or progesterone, usually in the form of hormone replacement therapy, for a long time, consistently over an extended period of time. Postmenopausal obesity is an independent risk factor for breast cancer. So we always encourage good nutrition and eating well and maintaining a healthy lifestyle by doing exercise and moving as much as you can so that we can avoid postmenopausal obesity, which is that risk factor. Now, other things we can't modify, things like the hormonal influence you've had over your lifetime based on reproductive history, the age of your first menstrual cycle, the age of your menopause, the age of your first live birth, if you've had no children. You know, those things take a role in increasing risk. Family history increases your risk if you have a primary first degree relative with breast cancer. There are genetic mutations, the most common being BRCA or BRCA mutations that increase your risk for breast cancer.
What are some strategies that can help improve the health outcomes for the Latinx community in regards to breast cancer?
I really think it's education about early detection, education about where to get a mammogram, education about doing that annual breast exam plus the mammogram. This is the way that we find cancers early, which are very treatable and curable. You certainly don't want women to neglect something they see because of fear or concern, and sometimes, unfortunately, denial about it. We really want people to feel safe and comfortable coming in so we can help navigate that.
Are there any local or state programs that can help women in the Latinx community access resources that they may not be able to access?
Yes, there's a great organization called Alas Wings. It's alas-wings.org is the website. And it's a wonderful organization which allows empowerment of Hispanic women with education, with support resources, things like yoga, things like mobile salon, and other resource groups to guide women not only on early detection, but also on resources if women are diagnosed with cancer and they need help with the navigation.
Great. What are some things that healthcare providers can do to help decrease these disparities that Latinx women are facing?
It's a tough one. I just think outreach programs like this and making sure that we talk to the community, making sure that we maintain awareness in the community outside of our clinical work is very, very important. And so anytime that we can talk about it, I think really helps to improve outcomes in the end.
Now let's talk about the pandemic. How has the pandemic affected breast cancer screening and diagnosis, treatment?
Right. We saw a lot of women not getting their mammograms in 2020 because for a bit, many of the imaging suites were closed during the height of the pandemic. And then women were also not necessarily doing elective or preventive care during that year because it was risky. So now, and especially 2021 and 2022, we have been seeing women doing their mammograms again with sometimes some delay, but not necessarily changing the overall prognosis or not necessarily changing the outcomes. I think it's time will tell if we see any kind of increased rate of cancer detection in the years because of the pandemic. But it's good to see that people are now getting their mammograms so we can take care of them. Definitely. Now, another thing that we've seen in the pandemic is that women who get their COVID vaccination, we've been seeing increased lymph node size in the arm where the shot was administered. So it can be sometimes confusing on mammograms as to whether or not that is something reactive from the vaccination or is that something else or an abnormality. So we're trying to guide women on the timing of their best the timing of the mammogram relative to their vaccination while not delaying them. So it's good. It's a balance between the two.
Yeah, I actually read a few articles about that. Articles advising women to schedule their vaccine shots and their mammograms in a timely manner so it doesn't skew the results. Right.
So you want to time it where you're not doing the vaccination immediately before you get your mammogram, because we'll certainly see enlargement in those lymph nodes.
How far have we come in improving access and quality of breast health care in Chicago?
I think we're doing a good job. I think we're getting better at it. I think we can always improve. I know that in our clinic, our access is, we really want to see patients with a problem within 72 hours of them trying to get an appointment. I think that we really need to, again, improve education to women and also get the word out on how to get a mammogram if you don't have insurance, or if you don't have a primary care physician, we can help guide that. But we have breast navigators, as Equal Hope does, to help hopefully guide the women who struggle in that area.
And there are resources out there. It's, Equal Hope can make it an easy process. Allah's Wings can help with that too. So getting access to these resources for free to little to no cost, they're out there.
Agreed. And at our breast cancer center, we have a number to call that allows women to be guided in any way they need to in terms of if it's just getting a mammogram. You don't even need a prescription anymore for a mammogram. You can come in and get a screening mammogram.
Oh, that's good. I didn't know that you didn't need to.
Yeah, we can help provide that for you.
Okay, great.
Yeah.
Why is it important for women to be their own advocate when it comes to their breast health?
It's so important. I think that it starts with making sure that you, as a patient, recognize any changes that you may have in the breast. I think that it's important that you empower yourself with more information by going to see a physician who can be an expert in helping you diagnose the problem. I think that once you're within the system, we can certainly guide you, but it takes the individual to take that first step to seek out the care. And I think that in the end, being your own self advocate only bodes well in terms of the outcomes.
Correct. Yeah, I totally get that. What are some ways that women can lower their chance for breast cancer? Like simple ways they can start today and do.
Sure, sure. Again, it's about those modifiable risk factors, healthy lifestyle, avoid smoking, alcohol in moderation, maintaining a healthy, nutritious diet, maintaining a healthy weight with implementation of exercise, avoiding long-term consistent use of hormone therapy if you don't need it for quality of life changing symptoms, making sure you stay in touch with the healthcare provider, primary care physician, gynecologist once a year for an exam, just to touch base and recognize problems early. I think these kinds of changes can go a long way, not only for breast health, but for heart health and overall health. I think that, again, it's that concept of being your own self advocate and empowering yourself with information, and preventive health is such a good way to start.
And preventative health is what you can do to have better health outcomes in the end if you do have breast cancer.
Correct.
So what advice do you have for women who are still hesitant in getting a mammogram, who are scared to make that call?
Yeah. I feel like you should take it from me as a surgeon who sees hundreds of patients. It really is a well-tolerated procedure or imaging technique. It helps us help you if we can find the root of the problem or diagnose the problem early. And I think that once you do the mammogram the first time, you'll see that you can do it and that it wasn't as scary as you might have thought.
Yeah, it's very simple.
Yes, and in terms of being afraid of what we're going to find, again, I want to emphasize that information is so powerful, and we're here as breast specialists to help guide you with that information, to get you to what most of the time is a cure and moving on with your life. Okay? So I think that is my best advice.
That's some really good advice for all the men and women out there who are afraid to make the call. All it takes is one call, and you can get in and get your mammogram and take care of your health. So that's all the time that we have today. I'd like to thank Dr. Perez for being on the show. Thank you for educating us about breast cancer and how we can be advocates for ourselves and to take initiative. Cancer does not pause during a pandemic. Okay, well, thank you everyone for joining us tonight. We'll be back every fourth Tuesday of the month from 5 to 5:30 p.m. and hopefully we'll get to see you at the South Shore Cultural Center this Sunday, May 1st from 12 to 4 p.m. Good night, everyone.